going to talk about the IFPEP, the individual version of working with families. I'm going to kind of very briskly go through anything that was really pretty much the same from doing the group-based intervention, but we do a couple of things a little bit differently. So again, we start always with kind of going over feelings and feelings thermometer. And you don't have to be as formal, obviously, with news of the week. If it's just you and the kid, you just kind of have that touch-base conversation. And if you've done the assessment, hey, how are things going since the last time I've seen you? Kind of that obvious therapeutic stuff that is the spoonful of sugar that makes that medicine go down. So we start with a review preview. First session, it's just all preview. We talk about what are symptoms of depression and mania, the comorbidity, the motto, the fix-it list, everything just like we did before. So session 1 is really pretty similar. Again, it's your standard kind of 45 to 50-minute therapy session. We don't do the group activity, obviously, because it's just the child. So it's more one-on-one, and you can, again, kind of more tailor it to the child. But session 1 looks pretty similar. Session 2, we do naming the enemy. We talk about different kinds of treatment and medication, just like we did. And here you can really tailor it to the individual child's needs, obviously. We go through breathing at the end of every session. Session 3 is where it differs a little bit. Here's where we add in healthy habits. And we kind of quickly go over sleeping, eating, exercise, and kind of the acronym I like here is SEE. You've got to see your way to a better solution, okay? And so we talk about enough sleep on a consistent schedule, and healthy eating and regular exercise leads you to a healthier body and a better mood. So we get them starting to think about what exercise, what daily activities help you stay healthy. And it might be, walking to school or walking to the school bus or kind of just naturally occurring things, not going, doesn't have to be going to the gym. But what do the kids do just to be physically active? What are some of you and your family's unhealthy habits? And then why are healthy habits important? And talking some about this, it helps your body, it helps clear your mind. We've got lots of data now that show that cognition improves with physical exercise. We have lots of data to show, particularly in adults and adolescents, not so much with kids, that physical exercise, particularly aerobic exercise, improves mood. So this is a great antidepressant. There are no bad side effects of exercise unless you exercise excessively, but we see not many kids who do that. So you feel good about yourself. It helps you deal with stress, improves your homework, reduces side effects of medication for the kids who are chunking out, improves mood, you avoid illness, you can help maintain a healthy weight. So what happens if I don't get enough sleep? What happens if I get too much sleep? And you'll get kids who start to get really bad headaches if they've just been sleeping too much. It's one of the things that they don't necessarily put together, but you can help them make that connection. And then start thinking about sleep hygiene, both during the week and then on the weekends. When do I go to bed? When do I think I fall asleep? When do I wake up, and what's my total sleep time? And then am I getting enough sleep? Do I feel tired routinely, or do I feel pretty energetic most of the time? If they're not getting enough sleep, then sleep might be their first priority. But you kind of quickly go through sleep, eating, exercise, and then you let the child choose which of these 3 things is kind of top on my priority list. What do I want to work on first? So we give them an example of a sleep chart, and then if they choose this as the first target they'll work on, then they start tracking this over time. Healthy eating, what's the importance of healthy eating? What happens when I don't eat healthy foods? What happens when I eat healthy foods? And for our kids, if they're on any medication where kind of constipation is an issue, then you really have to work on kind of getting the liquids in, getting the high fiber food in. So again, it might be combating a side effect, but you want to kind of help kids work through that if that's an issue. We go over the food pyramid with them. What are the healthy foods I eat? What are the unhealthy foods? Am I getting enough of the healthy stuff? And if not, then start tracking the eating patterns. What we really don't want to get into is a notion of dieting, or kind of, we don't want to be encouraging kind of negative body image. So you want to talk really it's all a focus on healthy lifestyle as opposed to, dieting or losing weight. We don't want that to ever kind of come across as the goal. And then exercise, again, what happens when I don't get enough exercise? What happens if I get too much exercise? Rarely a problem with our kids. We talk about their stretching, aerobic, and strengthening. How much of each of those do I do? And then you can monitor that. So again, we have the kids pick the one that matters kind of the most to them, and that's what they do from session 3. The breathing at the end of every session, same as we talked about in the MFPEP. Session 4, then we go back into the toolkit. Same kind of deal. And again, here, what you don't get is you don't get the group where the kids are all chiming in, but by now you really know this child and you can personalize it very much to the child you're working with. So these are all fairly much the same. Session 5, the thinking, feeling, doing that we did before. Session 6 is problem solving like we talked about in the group. Session 7, we go back and now we pick up a second healthy habit. We'll monitor, and all along we've been, so every week then after the first healthy habit, you're kind of just checking in on how that's going. The second time around, you can pick up on a second healthy habit to monitor a little bit. Now, let's say you're seeing a kid and they really don't have any issues in this area. This is where you can flex it. You're working with only one child and one family. If they don't need these units, you skip them. There are not a lot of kids who wouldn't benefit, particularly the sleep. I see very few kids with mood disorders who can't benefit from some sleep hygiene work. It's almost always a problem. So we kind of do a quick little review of all of this and have them pick a second one to monitor. Session 8, we go into the communication. And so here you do a lot more just charades and back and forth with the two of you in the room. It's kind of more fun in the group, but it definitely works well with just you and the child. Have them do that same exercise. Session 9, then we go on to verbal communication. And session 10 for the kids is a review. And here we don't do the big game, but we just kind of go through that reviewing of concepts. And what we really want kids to be able to do by the end is that taking ownership of, when you first came in, and then if you need in the bank sessions, you can again always put those in wherever they're needed for the child or for the parent. But by the end of any treatment, as I'm winding down with the family, I would really want the child to be able to say, do you remember what it was like when you first came in? What were some of the problems like that you were having? And how do you think you're doing now? And get them to do some evaluation of that. Say, well, what do you think it is that you're doing that's really made things better? And a lot of times kids will say, well, the medicine's really helped. And say, that's great. I'm so happy that the medicine is helping you. But I want you to tell me what you are doing differently now that's really helping you, because I know that you've been trying some new things. You really want the child to take ownership of the changes that they've made. Okay. So this is your chance to do that review, and then you bring the parents in. They get a nice little certificate, but it's a smaller graduation ceremony. Okay. Any questions on the kids in IFPEP? Not particularly different, other than we add those 2 healthy habit units in. For the parents, so the parents start out the same way. Again, we go over, and here you can really make it to the particular needs of the parents. And for some of these sessions, if you've got a family who's really been around the block, you might be able to combine session 1, child and parent, all into one session. Again, you've got all the flexibility you need. You might need a whole 24 sessions to get through this. You might find that you do the whole thing in 16. It kind of doesn't matter. You do what's going to work with the family, and you can do a lot more of that picking and choosing. If you don't have a big crisis point where you need to start right away with siblings or start right away with the school, would be some of your biggest examples, it makes the most sense to go in this order. You might be able to do some combining of parent and child sessions, but it logically, methodically builds on each other if you go through in this order. So starting again with kind of teaching about mood symptoms and keeping mood records, those are the same as before. Talking about medications. And then going on to working on what are those systems of care, talking about the school system in particular, and then you can do some really kind of in-depth problem solving with the family about school issues that they might be having, developing their treatment teams, and then moving into those negative cycles for the family and working through that thinking, feeling, doing. Then moving into problem solving. So far it's all kind of about the same. Whoops. And I skipped past this slide. So then session 6, you go back and kind of revisit. A lot of families are going to need, especially if they're new to treatment, are going to need a little bit more work on that school stuff. And here's a chance where you can do some of the drill down work and prepare for it, and prepare for a meeting with school personnel. So this might be where you video conference into the school team. If they're doing an IEP, it might be around the time that they're doing their planning session. It might be a special meeting at the beginning or the end of the year to plan for the coming year or to wrap up how the year went and kind of think forward to next year. So what you want to plan in the previous session is why you want to meet. Do you have goals? Do you need this session? If you don't need it, you don't do it. when to schedule, who to include, where to meet, what to discuss, how to evaluate. We've had school professionals who come to our session in our building. We do lots of video or phone conferencing. In some therapists, in some settings, are able to go out to schools. If you can do that, that's great, because then you really get a feel of the school and the building, and there's a kind of all that extra stuff that you learn by being in the school. So if your work setting permits that, I think that's ideal, but many work settings don't permit that. Then we move on and talk about communication, same as we've already reviewed. Then symptom management skills, like we talked about before. And now, if you're going to have a sibling session, and if it's not out of order, this is a great time to build it in. It's kind of toward the end. You've done a lot of the problem solving. Kids, the child with bipolar disorder can get very nervous about the sibling session. What are you going to tell them about me? Are you guys just going to complain about me? What's that all going to be about? I don't want them to meet you. You're my private person. There can be lots of feelings and thoughts about this. So again, you want to think through, if you're going to have a sibling session, why do you want the session? What are the goals and the issues? Who should attend? And how do you prepare how does the parent go home and prepare the kids for, why do I have to go see her? What's that about? If you've got a wide age range of siblings, it might be that the older ones come in, but the younger ones don't. So again, you kind of think through what the needs are and kind of what the point of that would be. It's very common that siblings might have some misperceptions. Parents might not fully understand what the sibling's discomfort is. And siblings oftentimes will try to protect the parent, like my poor mom's got enough to worry about without listening to me complaining, but meanwhile feels just kind of miserable inside. And not to add more guilt to the parent, we have no interest in that. But the parent needs to understand if they need to do some other planning for the sibling. Should the parent help arrange for there being another adult in this child's life? We also know that both from a genetic perspective as well as a family stress and environment perspective, if one child has a mood disorder, the sibling's at risk. So the sibling may have other bona fide disorders that maybe are less severity, but also warrant intervention and need a referral. So sometimes we end up providing, we do enough of a diagnostic screen that we say, I'm not going to be the therapist to work with the sibling. That gets a little murky. Doing individual therapy with two different kids in the same family, it often gets murky. But I've got a colleague, down the hall who would be really good at doing an evaluation, and I'm concerned about this and this and this in your child. So that might be one way that the sibling session goes. It might be that giving them a chance to vent and do some problem solving, and for the parent to recognize the sibling's needs. So there are lots of ways that sibling session can go. Can be very, very useful. So some issues to address, again, introduce each other, explain the purpose of the session, elicit and validate the siblings' concerns, provide some age-appropriate information about the mood disorder so they also understand what in the world is going on and why that sibling has such preferential treatment in the home.
Do you use mood disorders or do you say bipolar? What is your preference?
Well, since
not
this...
the sibling necessarily.
Right, so this treatment... Sure, so what label do we use? Since this treatment was really developed for kids with both depression and bipolar disorder, in these workbooks you see the term like mood disorder. But if the kid has bipolar disorder, then I use that term. Because I think, again, language is powerful. If the family has strong feelings, around privacy, and people will have, within a family, and this is a very important discussion to have. Let's say dad doesn't want anybody to know, because who knows what could happen if people find out that Frank has bipolar disorder. And mom's typical support strategy is to confide in her nearest and dearest friends and her sister, okay? So who does mom get to talk to? And then if the siblings find out, can they say outside the home, well, my brother has bipolar, that's why he has those problems. Is that okay with mom and dad? Is that not okay with mom and dad? Where are the privacy rules about communication? And there's really not a right or wrong answer, but there's an answer that works for that family. And most typically, the rule of thumb I go with is the person who feels the most distressed about privacy, try to follow that person's guide unless it really cramps the style too much of somebody else in the family. And then you have to do some family negotiation around that. So let's say mom really wants to tell her 3 best friends and her sister. Dad might need to give in a little. If dad doesn't want anybody to know, maybe mom needs to at least tell her sister because it's family, and maybe her one best friend, but maybe he really doesn't want the other best friend because, this and this connection or whatever. But you have to have discussion around that. And so where siblings find out, then it's kind of who do you tell, who do you not tell, who can the siblings talk to about this? And where is the family's comfort zone? Some families it's like, fine. And if nobody cares, then it's fine. And if the kid doesn't care, then it's fine. Is that kind of, okay. So determine if a safe place is needed, as we talked about, kind of that safety zone, being able to lock yourself into your bedroom if needed, or someplace in the home, and help develop that plan. Ask about family roles. The sibling's job is to grow up and be a healthy adult. The sibling's job is not to be a third parent in the home. And so let's say it's a single parent home, or one parent who's frequently, because of work schedule, is not in the home. And the sibling might understandably think that the parent in the home needs some extra assistance and protection. That usually isn't such a good idea. So you've got to talk through why that would or would not be a good idea in the home, and come up with rules. And for the sibling to really know their job is to be a kid and to grow up and be a healthy adult. And that is their primary job in the family. Okay? But making that really overt is a useful thing. Share sibling issues with parents to increase support for them. It may come from the parent, it may come from some other adult. And then we wrap up with the parents. So there you see that. And with that, we have saved a little bit of time. I could go over the therapist manual for the group, but I think what I would rather do is take any remaining questions that you've got. We've got up to 15 minutes that we could still spend with each other. So, yes?
Do you have difficulty getting families to comply with doing their home projects? And if you have any successful strategies, then you should.
Sure. So great question. Do we have adherence to doing the projects at home? And if we have any tips for success, what are they? Okay. Getting the kids to really want the parents to do it is great. And how do we do that in part? Points. So the kids get, 8 to 12s. I love that age group because they want their points. And so coming back with family projects, if the family, and you can tell if they did it on the car ride in and they discussed it at the last minute, or if all the kid handwriting and the language that the kid supposedly said sounds really adultified, you kind of wonder. And then if the kid says, oh yeah, my mom just did that as my dad was driving us to the session today. And now the mom's kind of been called out and the dad's been called out a little bit right in front of everybody. That's just a little embarrassing. So what would we do? So the kid loves getting the points, and they get points for bringing in the projects, so that's helpful. The parent therapist in the MFPEP or the IFPEP would go back a little bit to saying, we have such a small amount of time together, really. Don't mean to lean on you here, but we really, boy, the more you do this, the more you're going to get out of it and benefit. And in fact, we've actually done a study where we have looked at whether or not families do their projects, and families who really do the projects really had the most treatment success. I mean, we actually have data to back that up. It's not just us thinking that. We have data. We can show you that. So that's a little bit helpful. I think those are probably some of the biggest things. And they really do share in front of everybody else, so there's a little bit of social humiliation if you haven't done it. We play that for all it's worth. Yes?
On a related note, on your follow-up, did you try to find out if they were still using these strategies?
So a 12 and 18-month follow-up. We kind of informally, so the question is, were people continuing to use these strategies? Part of what we did, and I didn't present all of those data today, but Amy Mendenhall, for her doctoral dissertation, was very interested in our services data. And because our treatment was purely those 8 sessions of group and nothing else, we were not doing the medication management in our clinic. We weren't providing other services in our clinic, unless they just happened to be from our clinic, but we really had families from throughout the state of Ohio. Most of them did not come to OSU for clinical care other than this group. So we very meticulously measured the medications they were getting, the other psychotherapy they were getting, the school-based services they were getting, and then any other kind of, like, were they at a therapeutic summer camp, were they getting big brothers, big sisters, were they getting any respite, et cetera. So we had 2 independent clinician researchers separately evaluate. We were masked, I was one of them, I had another clinician doing this. We were masked to whether the kids were in the immediate treatment group or the waitlist group, and we just rated the quality of their service after we had all of these questions from the parents and the kids on what services they were receiving. So part of what we learned, which is what we had expected, again, going back to that very beginning slide, we think that if you provide information and skills and support, families will have a better understanding. Better understanding leads to better treatment and less family conflict, which leads to better outcome. So it's kind of like a double mediation model, and Amy tested that in her dissertation, and that's exactly what she found. So you really, if you go through those stepping stones, that's really kind of the process by which it seems that kids get better. So it's a very long-winded partial answer to your question. When parents became better consumers of care for their child, the kids did better. So part of it was, I'm sure, and then when we did the phone calls on a more informal basis, people would talk about, oh yeah, we've got we keep our binder on the kitchen counter, and we pull it out whenever we need a reminder. So some families very overtly just offered that up. We didn't specifically say how much of these specific techniques are you using, which would have been interesting. How truthfully we would have gotten the true answer on that, I'm not sure. It would have kind of primed for, oh yes, we're using everything you told us. I'm not really sure how good those data would have been. But if thinking back on those exercises that we went through, they're the absolute building blocks of therapy. And there was nothing particularly novel about it. It's communication, it's problem solving, both nonverbal and verbal communication. It's kind of the rubrics of cognitive behavioral therapy. It's really those fundamental therapeutic skills. So whether they were with kind of thinking back on what they did in group, or maybe they went on to a new therapist, and we would always say, this is your starter kit. Take your workbook, keep working with your ongoing therapist. If you're in ongoing psychotherapy, please keep working on these ideas. Take this has worked for you, keep going back to it. So hopefully they did. Any other questions? Yes?
We're all with ADHD kids here, and certainly a number of them are very appropriate for this. Is there anything particularly from a parent training perspective, and that you advise us not to do that we might typically do with parents of ADHD kids, when the kids might also have prominent mood dysregulation?
That's a great question, and it goes back to that notion of can'ts and won'ts, and separating out, because the behavioral stuff, I mean, you all here are experts in parent management training, in how to effectively parent a child with ADHD. And a lot of very clear behavioral skills are what works. What doesn't work is if the child is grandiose, if they are just hopelessly dysphoric, if they are suicidal, if they're elevated mood. Those same wonderful behavioral strategies over here not only are ineffective over here, they might exacerbate the symptom. So if you've got a child who's starting to spin out of control and you're trying to do nothing but clamp down behaviorally, it can escalate them even further. So now it's iatrogenic. So it's getting that wisdom of Solomon and training that up in the parent. And parents come to us with some innate sense of it. They might be more or less sophisticated, but they come with some sense of that, and we want to grow that sense. So when do you behaviorally sit on it? And when do you say, whoa, this is so driven by mood, and if we don't just stop this train, it's going to crash? Okay. So it's kind of getting that sense, if that makes sense. That's probably the biggest thing I would think of with kids who clearly have a fundamental primary behavioral disorder. Any other questions? Yes?
You do the parent and the child, do you bring them together at some point?
Oh, for IFPEP?
Yeah.
Yeah, I'm sorry, I should have described that at the beginning. So IFPEP kind of mimics what we do in group. So you start and end the sessions together. You do that kind of quick little check-in. So for the parent sessions are just parent sessions, and the kid is not at the parent sessions. But for a child session, you would start a little bit with just a touching base with the parent in the room also. Fairly quickly send the parent out. Do most of the session with the child, and then bring the parent. I'm so glad you asked this because I forgot to bring it up. Bring the parent back in at the end, and then the child goes over again. Here's what, here was the lesson of the day, and here's what the project is that we're going to go home and do. And that way, if the kid, you thought the kid understood it in the session, now they're explaining to their parent, and they've got a couple of things really not quite right, that's your chance. So that's part of the session. You kind of build in that time to make sure that the child got it right, and the family is really ready to go home and do their project, or the child is ready to go home and do her project.
And the group?
Group, it's the same kind of way, right? So we start and end together, and then depending on your physical setup, you either have the parents go to another room or you have the kids go to another room. You do the bulk of your session that way. The kids have to be in a room big enough that they can get up and move around a little bit and do their activities. Now I didn't describe, we have therapeutic games for every one of the sessions that I didn't go into talking about today. And then they come back together. Either the parents come back to the kids' room or vice versa. And the kids go through, you have 3 spokespersons. So one describes the lesson of the day, one describes the project that they're going to go home and do, and then one demonstrates the breathing exercise. So each time you kind of have that wrap up at the end. One thing that's different for healthy habits, for some of our kids, you need the parent in the room pretty much for the whole session. If younger kids, or if you're talking about diet and the child has, doesn't go to the grocery store, doesn't plan anything, for some kids you might find it's really more useful to do the healthy habits units with the parent pretty much in the room the whole time, particularly around eating, but also around, to some degree, around exercise, a little bit for sleep. So you might find that session's more like a half and half split between the child alone and the child with the parent. Yeah, that's a really important question. Any other questions? Okay. You've been a good audience. Thank you very much. It's been fun to be here.